badly symptomatic for a baseline condition that developed Takotsubo as a consequence, and as the primary pathology was not resolved, they eventually die of it. They have an autopsy to see what is Takotsubo immediately after its origin in an autopsy. Let's start with the first case. This was a lady, 28-year-old Afro-American, transferred to Houston from a city nearby while intubated and critically ill for the last 3 days before admission. She was sick from an acute illness that they would not be able to understand the cause. Initially, she fell suddenly sick with fever at 101 Fahrenheit and abdominal pain, nausea, and vomiting. Eventually, she started having dyspnea and hypertension, and for that reason, when the x-rays were clear at baseline, she was intubated to be sedated, and she developed, under the effect of propofol for general anesthesia, acidosis that was quite severe. At that point, the initial blood pressure was 110 over 140, accompanied by acute pulmonary edema at the time of intubation. The event became hypotension, and vasopressors were used after intubation. Because of worsening blood gases and leukocytosis, urinary infection was diagnosed, and eventually she was treated before transfer with Tamiflu, ibuprofen, Levothyroxine, acetaminophen, metformin. There was a question about diabetes, but she was never treated before for diabetes. And on admission, next, it was obvious that she was quite sick and quite unclear in its cause, and treatment was sort of tentative and symptomatic. Initially, KG on admission was normal, even though there was tachycardia. It probably was appropriate for the temperature. It was elevated. The initial echocardiogram that was done because of the hypertension was normal on day 1, and 2 out of 3 cardiac enzymes markers for determination were normal. Eventually, were mildly elevated. The BNP was 600, so no severe heart failure, but some elevation of it. Acute liver failure was diagnosed, and the question came to the cause of this condition is possibly related to an undiagnosed Tylenol and metformin intoxication, very unclear. Drug tests are still pending, but all the ones that were done were negative. Acute renal failure with anuria developed in day number 2, where the patient was on vasopressors. Cerebral edema by MRI was accompanied by mental depression, and the patient was unresponsive shortly after admission. She had a brief cardiac arrest on day 2, from which she came out with just massage and increased vasopressors. On day 3, she developed worsening of hypertension, bradycardia and ventricular tachycardia, ST elevation, and she was, before I saw her, she was transferred to the cath lab for ruling out the coronary artery disease that was diagnosed on the basis of the EKG. At the catheterization table, you will see the pictures. The diagnosis became confused, but most likely everybody thought in apical, like a pseudocardial, actually apical mid-ventricular cardiomyopathy as the cause of the recent collapse, but not really the initial cause of the acute condition. The echocardiogram after catheterization confirmed that there was a severe change in the left ventricular function, but let's see what we can see in the angiogram. So this is the left coronary artery injected selectively, showing pretty normal vascular treat, no spasm or no fixed stenosis. This was before nitroglycerin. Next. If there is any objection or question, you can stop at any time. The next is a right coronary artery injection, left anterior oblique, very large and dominant and healthy looking. So we went to left ventricular angiography. Ventricular angiography shows something that is quite amazing with a fairly innocent electrocardiogram. But the next day we confirmed that this was the real condition of our left ventricle. Basically, the middle two-thirds of the left ventricle were totally akinetic, while the apex and the base were hyperkinetic or normal kinetic, surely not so severely depressed as the mid-ventricular. This is what we call a typical mid-ventricular severe cardiomyopathy with an ejection fraction calculated as 18%. Next, this by echocardiogram shows exactly the same condition of her left ventricle as severely compromised in the mid ventricle. Or the next picture is better. It is interesting because it's a few hours before autopsy because she eventually degenerated and died within 6 hours of this angiogram, or 24 hours after this angiogram. So the apical portion of the left ventricle fairly preserved, the mid portion dyskinetic, the base mildly hypokinetic. Next. In another projection into chamber, also severely compromised the left ventricular function. She was evaluated for liver and kidney transplant. Obviously, there was no hope given the rapid evolution of the condition that was not known in its cause and not responding to any symptomatic treatment. And eventually, she died very quickly. Next, she had how about that? At autopsy, basically, they confirmed edema of the brain, severe, pulmonary edema of the lungs. The liver had no viable hepatocytes. Everything was necrotic, culminating hepatitis or hepatocellular necrosis. Also hyperacute severe renal tubular necrosis of everything, and histology of the heart that looked grossly normal, even though hypertrophic. The left ventricular, the heart rate was 350 at the upper end of normality. There was mild cardiomegaly with an interventricular septum of 1.2 millimeters, was the same as the free wall. So the histology of the left ventricle of the myocardium showed no evidence of acute myocardial infarction, no contraction time necrosis, and there was only a TFO of irrelevant importance. The cause of death was concluded to be likely severe intoxication, but by unknown causes. The complicating event of the terminal Takotsubo that did not respond to any treatment and led to death in pulmonary edema and shock was based on clinical data more than what was found in the autopsy. But it's interesting that even with a short evolution of the Takotsubo, one day in the hospital and she was in shock, this patient did not have any changes that can be recognized in an autopsy. And this is a consistent message that came from messages similar to this in the literature. In general, the conclusion being that patients with Takotsubo that die, if they are not diagnosed early after onset, will never be diagnosed in autopsy, because the evidence comes from the appearance of severe and typical pattern of hypokinesia or dyskinesia, and in autopsy there is no evidence either of coronary stenosis or occlusion, nor of the typical findings of this stage 24 hours, 48 hours, so the infarction would cause changes at the histological level. There was no change in this case. Evidently, it was something rapidly evolving, most likely spasm, that resolved by itself, even though the stunning had remained and caused the death, the mode of death, and not the ultimate cause.
Paolo, aren't you a little surprised that it wasn't dilated autopsy?
I didn't understand you. The sounds are not very good now. Can you repeat, please?
Can you hear me now?
Yes.
I'm surprised that the left ventricle wasn't dilated at autopsy.
Right. It was mild hypertrophy as the only abnormality, and we reviewed with the pathologist the findings. Definitely, there was nothing dramatic either to indicate an acute myopathy, nor obviously edema or hemorrhage, anything to suggest an hyperacute event. And I don't think that this has anything to do with the changes at the level of the brain, the lungs, or the liver and the kidneys. even though somebody could be dubious about the absence of the Takotsubo-like presentation on other organs. And nobody has ever published a case with spasms of other organs than the heart. I may have suggested in previous sessions that in some cases, probably close to 50% of the cases of Takotsubo, abdominal pain precedes cardiac manifestations. So it could be that there is at least abdominal or mesenteric spasm, but we could never show it even in cases that were obviously Takotsubo and were admitted initially in the videos with selective angiography and acetylcholine. We could not diagnose any narrowing from acetylcholine, and the nitroglycerin did not change anything.
And did you get a chance to infuse acetylcholine?
Now, this patient was so sick and they just barely had 3 injections in the coronary arteries and were returned to the CCU and died. I was not on the case at the time. They called it, the fellows made the diagnosis of mid-ventricular, and they were all excited and they were hoping to carry her out when it was not clear there was such a severe general multi-organ failure. We were expecting to be able to eventually demonstrate that this was spasm, but there was no chance. All right. The second case then is a 58-year-old. This is at the lowest level of severity, where a patient comes with something that could be, but we're not totally sure, and we do the acetylcholine as it should be when the clinical pattern is not totally manifested and you remain with some doubts. Let's see if you can agree that this possibly is a case of recurrent Takotsubo, of mild degree and reversible, like in Pitt's metalangio. 58-year-old lady known to a partner of mine because of mitral prolapse and hypertension, hyperlipidemia, but no history of coronary artery disease, has history of family with early coronary artery disease. She was admitted to the emergency room 30 minutes after onset of severe oppressive chest pain related to the left arm and accompanied by cold perspiration and dyspnea. She said her own testimony that this was obviously an acute infarction, she said, because she saw it in her father and in her brother. She was given sublingual nitroglycerin in the ambulance before they did the EKGs, either in the ambulance and in the emergency room, but those EKGs were normal, and the chest pain disappeared quickly. Cardiac enzymes were negative. She was sent to the diagnostic catheterization because the symptoms were so typical, and the patient was firm that this was a heart attack. So she went to the cath lab, and I was there. This is the baseline left coronary artery injection. Mildly thin distally, unfortunately, the slowness of the projection doesn't allow you to get the feeling for the flow rate, but it's a mildly decreased flow rate, especially in the LAD territory. At this point, it was something like an hour after nitroglycerin given sublingually before admission to the cath lab. Next. This is the same left coronary artery after injection of acetylcholine. Acetylcholine at 50 micrograms caused the repetition or reproduction of the same pain, violent, and you had cold perspiration, asked for help, and we stopped at 50 micrograms. With these images, they are mildly worse than the previous, especially in the LAD territory. I wouldn't be totally convinced until I would see something more in the left ventricular function or in the nitroglycerin response. The nitroglycerin shows mild improvement. A little larger, the diameter of this LAD was 1 millimeter at baseline and became 0.7 with stimulation of acetylcholine, and now is something like 2 millimeters. Nothing terrible or typical of Takotsubo, but the presentation was less than dramatic and complete. So the left ventricle was done mainly because of the severity of the pain and the possibility that this was mitral valve prolapse related chest pain. But to me at least, not to everybody that observed this angiogram, but to me this looks suggestive of some mid-ventricular again Takotsubo, but let's see what you think. The mitral valve prolapse is trivial. Probably in the past, the mitral valve prolapse was diagnosed more liberally than currently. This will not be called mitral valve prolapse at this time. So there is no good explanation or likely explanation for the chest pain from the mitral valve, and we remain with a mildly depressed mid-segment of the left ventricle. So we go to the echocardiogram that we wanted to do at this time, and eventually follow through in the follow-up to demonstrate if there was a recovering of the normal function. So this is the first echo. It is in some projection suggested, in some other could be called normal. The lady had, by a report, we couldn't see yet in a normal ventricular function some years back, and minimal mitral valve prolapse actually was not called mitral valve prolapse. With the affinity contrast more clear, but as you exit the middle of the ventricle, the left ventricular function seems to be close to normal here. Let's see the next. This is probably more suggestive. The apex doesn't move in, but it is not really diagnostic in my perception. What do you think, Jonathan and Eric? Could it be solved as in my case of Takotsubo?
Yeah, without the facilitation hard to say that this Subo, the LV motion, pretty normal.
You know, so we're going to show you the follow-up echocardiogram that was done 10 days after discharge. Clinically, the patient had done well until she came to the hospital, and she had chest pain again of the same kind coming to the echo lab. So this is with the echocardiogram during a resolving pain attack that was treated with nitroglycerin. You see the apical lateral portion of the left ventricle is slightly hypokinetic. Somebody said that the apex of the right ventricle could be also a little lazy. But as you said before, I'm not sure that this is the case of Takotsubo, but it could be in my case. So the apical portion could be less than brilliant. It surely cannot diagnose it by the reversal to normality in this case, because the patient had a new episode. You know, was that an episode of coronary spasm again, or coronary event, or ventricular Takotsubo again, or was it a new cardiac event? In this picture, probably more than in the others, it's a little more suggestive without being 100% diagnostic.
And were there any EKG changes this time with her chest pain?
No, it was not changed a few minutes after when we did it, and the pain had already gone at that point. So this is the typical manifestation that causes more discussion than final diagnosis, even with the acetylcholine. But the stronger case for being this Takotsubo related is the response to acetylcholine. The pain was exactly the same, was severe, and it disappeared immediately with nitroglycerin. But in one case, you can go back to this slide. In one case, we have an intractable, severe condition with shock, edema, and everything else. Reduction of anesthesia with propofol that was reported in the past to be able to cause Takotsubo. Takotsubo comes and causes death, most likely because Takotsubo recurred. But the fact is that Takotsubo, 24 hours after an angiogram that showed a severe impairment of the left ventricle, was not accompanied by any irreversible damages in the myocardial territory. This, the pathologist said this could be used for transplant. Evidently, we don't know if this patient would have had post-transplant Takotsubo again. You know that this is an interesting discussion that came to the literature recently about patients that donate their heart when they are brain dead from brain trauma or subdural hematoma. Typically, they are considered for transplant and eventually are transplanted, and many have dysfunction, and an EKG that is totally abnormal. And that literature tends to conclude that Takotsubo is actually the manifestation of the pathology causing T changes or ST changes during brain pathology, acute brain pathology, and EKG changes in neurology. They proposed recently to call that Takotsubo in place of subdural hematoma-related cardiomyopathy. So at this point, we can entertain a brief discussion about what was proposed. This is the case of the Takatsubo that was very clear, mid-ventricular cause of death, even though it was a complicated event in something much more complicated. Next. This is usually related to something we couldn't show in this case. Which is a spasm of every single vessel but the LAD. Anyway, we don't have it, but it's the concept we were saying that mid-ventricular Takatsubo, at least in one case of our, two cases of ours, was reproduced with acetylcholine exactly with the same left ventricular dysfunction pattern of the mid segments of the left ventricle with the spasm induced by acetylcholine in every vessel, but the LAD was spared. So in many
what distribution is dysfunction apex?
The apex comes when everything else is severely spastic, but the LAD remains open. The LAD epicardial vessel. Probably there is a diffuse septal narrowing, and diagonal in those two cases disappear too. But in general, the pattern of spasm induced by acetylcholine that resolves with nitroglycerin is uneven with relatively spared LAD territory at the apex. The apex still receives blood. Yeah, this is it. Okay, this is
and do you have examples of that with acetylcholine where you've infused it and you see spasm?
This is the diagram from the paper we published in the Mayo Clinic proceeding. This is the first case of mid-ventricular Takatsubo reproduced and had no serious spasm. There was diffuse narrowing, but not total occlusion of the LAD, while the diagonal, the circumflex of Magna 1 and 2 and right distal vessels were all subtotally occluded. All right. Do we have another case?
Well, I have a case. It's not a coronary anomaly case. It's a case of pseudoaneurysm of the aorta. So I don't know. Eric, do you have a case?
No, I don't have a case.
So let's go ahead and show briefly because I need to go to another conference.
Okay, so do you want to give me control of the computer?
Janelle is there.
Dr. Thomas, you should have control.
Yeah, show my screen. Okay. Okay, can you see the screen?
Excellent.
Okay.
Fine, I can see it fine.
Yeah, I'm going to put you on speakerphone. Can you hear me now?
Excellent.
Okay. So this is a 58-year-old man. I'm having a lot of echo feedback. I don't know if I can do anything about that.
Dr. Angelini, are you on mute?
No.
If you can mute yourself while you're not speaking, there won't be any feedback.
Okay, so yeah, that's better. Now I don't hear any echo. So 58-year-old man had an ascending dissecting aortic aneurysm and resection, and it placed a Dacron graft in at age 39. He had bicuspid aortic valve and severe AI, and so also underwent replacement of his aortic valve with St. Jude valve. Had some coronary artery disease, a heavy smoker, and so they put a vein graft into the PDA, sewing it into the proximal. The anastomosis was into the Dacron patch of the aorta graft. Then, about 8 years later, he was diagnosed with a pseudoaneurysm of the aorta due to the vein graft dehiscence from the proximal anastomosis with the Dacron graft. And so this was, he had a second operation that was repaired with a pericardial patch. And the vein graft was reattached to the pericardial patch, not directly to the Dacron, through an incision, though, in the Dacron patch. All right, so pretty complicated surgery. And then he presented with this, with a mass on CT as outlined here. You can all see that. And here are some other views of it. I think it's seen very well in the lateral view. You can even see the neck of that coming up. And here, not exactly sure which one. I don't think it's this, but it might be in this LAO view. I mean, in this PA view. The chest X-ray just shows an enlarged heart. This is all of his aorta. It's very tortuous and very difficult to cannulate. Anyway, the pseudoaneurysm measured 7 by 6 centimeters, and his native right coronary artery was occluded, and the bypass graft was also aneurysmal, 1.8 centimeters in diameter. Let's see. His echo showed ejection fraction about 40%, global hypokinesia, and then we cath him, and I'm going to show you the angiograms, and we tried to close the pseudoaneurysm. Let me put this up on this. There we go. So here's a pigtail. You can see the tortuous root of his aorta trying to get up there. Here's his aortic valve. He's got sort of an aneurysmal dilatation of the ascending aorta, which is the graft, but you don't really appreciate the pseudoaneurysm here. In the LAO view, you can see the pseudoaneurysm. That whole area. So finally, we were able to get a left internal mammary artery guiding catheter, 6 French guiding catheter, up to the orifice, and then injected through a glide catheter. This is a 4 French catheter that's up into the pseudoaneurysm itself. You can see the dye sort of going around the posterior aspect of it and refluxing back out into the aorta. So we thought we would try and coil this. The surgeons did not want to go back and operate a third time on this man. So we used these bird nest coils, interlocking coils, and started placing a number of them, as you can see here. But going through the gliding catheter, the interlocking coils actually interact with the hydrophilic coating of the glide catheter. We didn't know that at the time, and so the interlocking coils eventually would get gummed up and wouldn't go out. And so this is an attempt to try and retrieve the coil, and the coil uncoils. And so we've got part of the coil in here and part of the coil back up into the catheter. So we then had to retrieve that. There's a snare inside the catheter here. So we've snared the end of the loop. You can see how the coil is unraveled here. And so we grabbed the end of that, and ultimately we were able to remove this whole coil, the last coil that we had put in. So at that point, you can see we've got 10 coils in here, and it's maybe filling a third of the aneurysm. So we felt we needed to do something different, and so we then attempted to place an Amplatz or vascular coil into this tear. So that's not so much a hole in this with the neck of the pseudoaneurysm as much as it is a tear along the suture line between the patch that was put onto the Dacron graft. So we were able to get a small catheter and then pass these this vascular plug 4, Amplatz or vascular plug 4 through there. So this is, you can see there's still a fair amount of blood flow around this first plug. We were then able to get a second plug in. And there's a lot less blood flow. There's a little bit of blood flow going into it, but not as much as before. What you're not seeing here is that there's a vein graft from nearby, near this area, which is then filling the right coronary artery. So that's where we stopped. This was about a month, 6 weeks ago, and we got a follow-up coronary CT study. Right, let me get rid of this. Yeah. I had this up here, but it timed out. So let me try and bring this up. So we brought him back today, and I'm going to show you the angiograms that we have just from today. So here's all the coils that we had placed in the pseudoaneurysm. These 4 dots represent the 2 Amplatzer plugs. Here's his aortic valve, and then through a 60-centimeter long sheath, because of the severe tortuosity in his aorta, is able to get a diagnostic right coronary catheter there. That doesn't show up too much. But now you can see with this injection, there's still a large amount of contrast getting into this pseudoaneurysm. And now also for the first time, you can see this vein graft, which is very patulous, aneurysmal, also has a stenosis over here as well. And then it doesn't seem to feed a lot of territory of the inferior wall of his native vessel. So I'm just going to show you some of the other diagnostic studies here, again filling up a lot of the pseudoaneurysm. I tried putting a guide wire in here. I couldn't get it down very far. This is a transit catheter. I injected through the transit catheter. That doesn't help very much. Here's the guide wire going up into the pseudoaneurysm with an injection to stabilize it. So I think we get somewhat better images of the vein graft here. I think you can appreciate it's pretty tight right there. Here's an aerial view of that. So quite tight. And the vein graft, the native artery is not that big down here. So the options are to send this guy back to surgery, but the surgeon is very reluctant to do that. He feels it'll be a fairly high mortality. And the other option would be to put an Amplatzer device in here that would close off the vein graft, but also would close off this access into the, may close off the access into the pseudoaneurysm. I had been reluctant to do that previously because we didn't have adequate pictures of what this looks like. And, but now I'm thinking that that would be a preferable approach. You'd have a small inferior wall infarction, but that would be a lower risk than bypass surgery. We looked at his left coronary artery, and there's some mild disease, nothing too bad, but he does have collaterals to his inferior wall. So I don't think his infarct would be excessive. Here's a final picture of the collaterals to the inferior wall, the right coronary artery. So anyway, that's my plan now. Any ideas or suggestions?
Dr. Angelini, are you unmuted?
Sorry, Dr. Eric. Dr. Angelini needs to go.
Oh, okay. So he's not there anymore.
No,
he just step out.
Okay. Well, any ideas, everybody?
Well, that's certainly, you're very bold, but it takes bold hearts to win fair maidens. But I'm very impressed by this entire case. I think you got a good plan. I can't say that I've ever had such an ambitious approach to such a complicated case, and my hat's off to you.
Well, thank you, but you know, I think it's because the surgeon, who's an excellent surgeon, you know, has been in there twice. They'd have to replace the whole aortic root again, I guess, and for a third operation, not too enthusiastic. So I think it's a reasonable approach. The problem is I'm not even going to work, depending on how big the opening is in the aneurysm. But I will let you know if I'm going to talk to the surgeon and the patient this afternoon. If we both agree, then we'll go ahead and try it in the next couple of weeks.
Is Dr. Angelini back on?
No, sir. We need another meeting right now.
So he's gone. It's by Eric. It's a different meeting. All right. Well,
so that's very interesting. Did you inject the native right?
No, the native right is closed based on, first of all, you can see the collaterals from the left injection, and the CT angiogram showed that the native right was occluded in its mid portion.
Okay, because we're having a lot more experience with CTOs, and if you did occlude the saphenous vein graft and had problems from that, you still can consider a CTO there, right?
That's a possibility, except this fellow's anatomy is so tortuous, his aorta, and trying to cannulate the arteries. You can see I used a left Amplatz 2, which barely reached the left coronary. It would be very difficult. His aortic root is dilated right above the sinuses of Valsalva.
Was that an Amplatz 2 or Amplatz 3? It looked pretty big.
Yeah, this is an AL2. but I think it could have taken an AL3 to get in there. There's a huge aneurysm there. So I'm not too optimistic that an angioplasty, especially a CTO, where you need pretty good backup support, would be successful here.
I'd love to see what you found the resolve there. That's a very interesting case.
Yeah. Well, it may be that we put some kind of Van Platz or vascular plug in there, and even though it closes, let's say, the vein graft, it doesn't completely close the aneurysm. So he might wind up with surgery anyway, but at least it's an attempt to try and avoid that.
Excellent. I'm interested in seeing the follow-up. It looks like we'll call it quits at this time and get back together the second Wednesday in December.
Very good.
Let me know if you have any cases, Jonathan.
Very good. Okay, thanks, Howard.
Thanks a lot. Bye-bye.
No later. Bye.
All right, we're done.